Bismillahirrahmanirrahim. Thank you very much, Professor Sonia, for the kind introduction. Thank you for the kind thank for this chair for the invitation. Thank Amgen for the invitation as well. I'm waiting for my presentation to be loaded. Well, another topic of bleeding as well. This is my disclosure, and this is my agenda rapidly. And immune cytopenia, an old disease. It will never be an old. Fields are evolving in the clinical picture, the presentation, and the pathogenesis every day about the ITP. If you do a search, I guess it's a disease which is very vital and very commonly encountered for all of us at our clinic, at our practice. The ITP, as we all know, it's an immune disorder, starting from the abnormal presentation by the platelet by the platelet itself, or antigen-presenting cell, or back by the macrophage to the T helper cell, with the marked skewing for the T helper 1 and predominance of T helper 1 and the T helper 17, as all of us are is very famous over the last few years about the incrimination in the autoimmune disorder, ending up by stimulation of B cell, by the B cell, production of antibody. The antibody coated with the platelets goes to either to the macrophage for engulfing, or by the Fc receptor to the spleen with the famous SYK receptor, which is again some famity over the last few years, or the abnormality of the Treg with the down-regulation of the Treg, predominance of the cytotoxic and direct cytotoxicity for the platelets. So talking about ITP as an interplay, ending up by antibody formation, complement mediation, but it's not very famous for the targeting, and cytotoxic T cell attack of the platelets. The antibody, it may attack the megas themselves, going to suppression of the megakaryopoiesis, or the direct attack of the platelets, and the cytotoxic T lymphocyte, they directly attack by direct T cell cytotoxicity to the platelets. This, by the pathogenesis, the complex interplay, ending up by targeting the therapeutic impact. The therapeutic impact either goes for the direct attack of the blocking of the spleen and its receptor by the intravenous immunoglobulin and sometimes splenectomy, or the gamma C receptor in the new drug fosfamatinib I will mention at the end of the slides, or attack of the B cell by the anti-B, which is rituximab, or immune suppression either directly to the T helper 1 and T helper 17, or the B cells as we mentioned before, or attack of many of the old medications like the MMF, and recently the rapamune or sirolimus we are using frequently in the ITP management over the last couple of years. And going back to the same slide, or stimulation of the megakaryopoiesis by recombinant by the thrombopoietin receptor agonist. We all use several guidelines. The most famous is the ASH, the American Society of Hematology 2019, and as we all know, they advocate against, or they recommend against the bone marrow examination at the upfront presentation in the typical cases of ITP, and they do not do H. pylori, because this is a very common practice at the presentation to find an adult hematologist doing H. pylori for the pediatric. We do not encounter H. pylori related immune thrombocytopenia in the pediatric age group as common practice, and we sometimes encounter it post MMR, so it's one of the major contribution of the American Society to plot that MMR may lead to secondary ITP. The newly diagnosed patient, are they managed as outpatient or inpatient? This is a debate as well. There is a tendency to keep them out of the hospital, especially if the platelet is more than 20,000. Yet I wanted to highlight a remark plotted by the American Society of Hematology that the patient with uncertainty about the diagnosis, those with social concern, those who live far from the hospital, and those who follow up who could not be properly guaranteed the admission may be preferred, because we we are in a condition that sometimes we cannot get proper access to follow up with the patient, especially in faraway area from the hospital. And this is also not only for the patients with platelet count less than 20,000. Sometimes we are pushed to that when the platelet count is more than 20,000. And the patient with ITP at upfront presentation, he needs to visit the hospital and then to be seen by hematologists within 24 to 72 hours after the presentation to the hospital. To treat or not to treat, again, a debate, especially in the first presentation with the fear of the patient and so on. So the American Society of Hematology advocate or recommends against the treatment if the patient do not have bleed, so observation rather than steroid and rather than intravenous immunoglobulin. If I'm pushed to give steroid, either the patient have minimal bleed or the patient have bad quality of life, so I'm pushed to give steroid. It's short term, maximum 7 days, never beyond 7 days full dose steroids. And the prednisolone or sometimes the dexamethasone, actually in the pediatric age group we have tendency to use prednisolone. Corticosteroid versus intravenous immunoglobulin in Egypt and even in USA with these recommendation, the ASH recommends corticosteroid rather than intravenous immunoglobulin for the upfront treatment of the patient with ITP with non-life-threatening mucosal bleed. And then, if the patient do not respond to first line, even he's newly diagnosed, the first 3 months, we have to end up by a second line. So second line treatment for the immune thrombocytopenia. The American Society again goes for the thrombopoietin receptor agonist rather than rituximab, rather than splenectomy. For sure, there is long time since we did a splenectomy for a patient with immune thrombocytopenia in pediatric age group, and rituximab is preferred than splenectomy if I do not have access to the thrombopoietin receptor agonist. And this is the North American recommendation, the same concept in initial disease, either no treatment or short course of steroids. If the ITP is persistent or chronic, better to do watchful watching if the patient permits me, I mean if the patient do not have bleeding manifestation and so on, and give rescue medication if needed. And then if I need medical treatment, the first choice is the thrombopoietin receptor agonist, and then to give emergency medication if the patient had bleeding, like rescue bleed. And if the patient do not respond to thrombopoietin receptor agonist, first line is to switch the thrombopoietin receptor agonist to another one of the thrombopoietin receptor agonists, plus or minus mycophenolate mofetil or other immunosuppressor, or to give rituximab with dexamethasone, or at the end of the day consider splenectomy. And I guess all of us know that splenectomy is not anymore a line of treatment in the pediatric patients with ITP. And I would like to advocate for the Egyptian guidelines. We're putting Egyptian guidelines for several of the hematological disorder and several of the pediatric disorder, and we'll release so soon the upfront presentation with the patient coming in the ER or the general pediatric clinic with thrombocytopenia at upfront presentation, how to manage those patients. It will be released so soon, inshallah. Thrombopoietin. Thrombopoietin is a complex protein with 353 amino acids secreted from the hepatocyte, from the liver. Very long hematopoietic compared to erythropoietin, for example. It's very long protein. What's its role? It's comparable to erythropoietin in a red cell. They are secreted, but in this time not from the kidney but the hepatocyte, and it have a biofeedback from when thrombocytopenia is present. The hepatocyte are stimulated, and the patient have a rise of thrombopoietin to compensate for the thrombocytopenia and so on. Yet in the immune thrombocytopenia, they found that the response of the thrombopoietin is not that adequate. So comparing the patient with aplastic anemia in the middle column to the immunothrombocytopenia and the maximum thrombopoietin level, the jump or the response of the aplastic anemia is much more better than the immunothrombocytopenia as regards the thrombopoietin response. Coming to the thrombopoietin, we'll use thrombopoietin analog or agonist or receptor agonist. So Romiplostim. Romiplostim is one of the thrombopoietin receptor agonists. It contains two domains, an antibody or Fc domain and a peptide-containing domain. They are peptibody, the thrombopoietin themselves. This peptide domain is the one responsible for attachment or for the MPL. The MPL is the thrombopoietin receptor. The Fc domain is responsible for the prolongation of the half-life of the Romiplostim. It's almost 120 to 140 hours for the circulation because it's internalized by the Fc receptor, and it acts by competitive inhibition on the MPL or thrombopoietin receptor with the endogenous thrombopoietin. This is the structure. When it attached to the MPL or thrombopoietin receptor, it activates many intracellular signaling. The most famous is JAK2/STAT5 and other signaling pathway. Like I liked very much the PI3K. Or everybody who knows me knows that I'm interested in the PI3K pathway. And then RAS, RAF, and MEK/ERK, and going into thrombopoiesis. Romiplostim, if it's given, the platelet count is expected to start to rise by day 5 if the proper dose is given, and then it peaks by day 12. I wanted to mention the reconstitution because its reconstitution, the 250 mic is reconstituted with 0.72 ml, giving 250 in 0.5 ml. This is the concentration of the final vial reconstituted. It's never shaken like any biological product, and it's kept refrigerated in 2 to 8 degrees Celsius. The Romiplostim gained the approval, FDA approval in the pediatric age group with ITP in 2018. The other thrombopoietin receptor agonist which we're using in practice is the L-Thrombopag. L-Thrombopag, it's not functioned by the same receptor. It's attached to the transmembrane portion of the thrombopoietin receptor. The L-Thrombopag it's an oral, so it's one of the oral medication which is not one of the privileges for using instead of subcutaneous. Yet the problem is that it has 60% hepatic metabolism, and the plasma level it's related to the hepatic function, so it should need to be taken cautiously in the patient with elevated liver function. And the plasma concentration of the L-Thrombopag is affected by the present in diet of any divalent cation like calcium. So it needs the dietary precautions in the L-Thrombopag need to be cautiously followed to have a proper response in the L-Thrombopag. And it has some drug-drug metabolism with for example, one of the famous in the adult, not concerned much in the pediatric age group, with the statins. The Romiplostim dose is 1 mic per kg as per prescribing as per prescription in the end plate. It's 1 mic per kg per week, and it's increased according to the level of the platelet count. If the platelet is less than 50,000 per microliter, so the increment will be 1 mic per kg per week. And when it reached to 250 as per prescribing, but I mentioned in the next slide some of my concern about stopping, it needs to be stopped till the decline to 150, and then to give a less dose than the previous dosing. If it's received 1 mic less than the previous dose. The dosing regimen, there was a recommendation from James Bussell in Blood Journal, and I'm inclined very much to those recommendations that when it is less than 400, it does not need to be stopped. We may increase the dose because stopping poses the risk of rebound thrombocytopenia in patients with the stoppage or the interruption of therapy. So better to keep and decline the dose, I guess, by recommendation of James Bussell. And this is what I just mentioned. When it's appropriate to discontinue, what we will do, many tapering recommendations. So it's tapering. It's not abrupt stoppage. So it's tapering. So one of the all of them dependent on consensus recommendation or expert opinion. 1 mic per kg decline per week, 2 mic per kg decline per week, and I quoted this from one of the recommendation: 25% decline every 2 weeks. What's the concern of abrupt stoppage? Again, rebound thrombocytopenia, even or especially in responding patients. So and the patient even after stoppage should be followed for at least 2 weeks for the platelet count because of the rebound thrombocytopenia. What about the efficacy data of Romiplostim? There is many publication. I quoted some of the well-designed clinical trial. So this trial, they recruited patients with pediatric patients with ITP more than 6 months since the diagnosis, who are refractory to prior therapy. The number was 62, and they randomized in a 2-to-1 Romiplostim versus placebo, and they followed up for the patient for 24 weeks. As I mentioned, the inclusion criteria, the exclusion, any bone marrow disorder, any rituximab, recent rituximab, because it may impact the response, because sometimes rituximab give a late response, or the patient undergoing a splenectomy 4 weeks prior to the screening period. And the endpoint in this study was efficacy, was a durable platelet response, and they meant by durable platelet response that the patient maintain a platelet count more than 50 for a 6 weeks out of the 8 weeks follow-up period. And those are the demographic data of the patients which were included in the trial. The time since ITP diagnosis was almost 2 years. Most of the patients have received at least 1 line, and almost 20 of the patients have failed 3 lines of treatment. What are the response or the efficacy data of this trial of the 42 patients Romiplostim, 20 placebo? And let's look on the chart on the left side. There was almost 52% reduction in the prevalence of the platelet response. The platelet response in the patient with هون عدت 20. لا اشوف بس الوقت ضايع. حاضر هحاول اجري بس لسه شويه. طيب durable response were noticed in the Romiplostim group, and I want to mention that the Romiplostim dose used was 5.5, and look at the middle column, the younger age has used a higher Romiplostim dose. And the adverse event was very manageable in this short duration of the study. As regard the extension trial, they recruited patients from several trials, ending up by one of the extension was 109 weeks, and one of them was 360 weeks. And let's escape the demographic trial, but most of them have failed several lines of treatment. And as regards the serious adverse event, there was antibody. We have concern of antibody against Romiplostim. So patient there was analysis for anti-Romiplostim on a yearly basis, and there was one patient developed anti-Romiplostim antibody. What's very important that no patient had has persistent antibody, and they did not have cross-reactivity with the endogenous thrombopoietin. I'm running on. What's very noticeable in this trial, that 23% of the patients with long-lasting ITP, the minimal ITP prior to presentation was 2 years. They have a median, 23 of them, they have a treatment-free interval after the duration. That means that they stopped any line of treatment, including the Romiplostim, which is very important, strong point in this trial. And those are the 3 well-designed clinical trials with extension phase. And I just want to push that 23 of the patients, they stopped any medication after being refractory to all lines of treatment. And there was speculations about how the Romiplostim do this, how did it prolong the disease duration, so that the platelets are exposed to the immune system, like in a speculation like immune tolerance. Maybe, I don't know, it's not clear. Is there a risk of thrombosis? This is a meta-analysis about the thrombotic risk, and the whole thrombopoietin receptor agonist, the risk ratio was 1.5. So for the comments, it was not a significant impact. The immunogenicity had long been of concern, yet only 0.4% of the adult had neutralizing antibody. This percent was higher in the pediatric age group, but the antibody, they are waned, and there is no, as I mentioned before, cross-reactivity with the endogenous thrombopoietin. The thrombopoietin receptor agonists are a second line so far, so usually they are pushed to be used after for persistent ITP. No, it's second line, even in the newly diagnosed period. And for the second line, we have all as pediatric hematologists, we are concerned why to use a second line. So one of the publications using a second line pediatric bladder cancer recently, sometimes the quality of life of the patient when it's severely affected, or it's the top priority list for shifting to a second line, apart from the severity of the bleeding manifestations. So decision of wait and see is not an easy job in Egypt, I guess, for all of us. It depends. This is one of the consensus recommendations in Europe. So it depends on the side effect, the proximity to hospital, the patient quality. Some of the patients are attention deficit, they do so much injury and so on. So it's not an easy job to go and to watch the patient without anything. At some point, it's a hard decision. What about Romiplostim in newly diagnosed ITP? There's no proper randomized trial, but many retrospective data about the use of newly diagnosed ITP with proper efficacy. And I know that there is other lines in newly diagnosed, but sometimes the patient, if failed steroid, if failed intravenous immunoglobulin, sometimes the second is the Romiplostim or the L-Thrombopeg, they are used upfront after the steroid intravenous immunoglobulin. They are used sometimes in emergency setting, and this is very important because sometimes we need them for the emergency setting. And this is a publication very nice from Toulouse in France, and they reported 15 patients with bleeding newly diagnosed ITP, but none of them had intracranial bleed, but some of them had severe non-stop mucous membrane bleed up to dropping in hemoglobin, and they use Romiplostim. Even one single dose was useful in stopping of the bleed. In the COVID era has shifted the balance toward the Romiplostim receptor agonist, because all of us have been pushed away from using immunosuppressive because we did not know what's going on. How would the virus impact on the lung for the patient with immunosuppression, and even with cancer patients we are treating. So there was tendency toward avoidance of the immunosuppressive and toward use a safe medication. Romiplostim versus L-Thrombopeg, a dilemma which will never end. There's many comparative trials. I picked one of the pediatric age group, and they were comparable as regards the overall response. I'm finishing. 1 second. But yet the durable platelet response was very in the favor of Romiplostim. So you have to choose for your patients. There is a rationale for switch. We can switch after exhaustion the dose of one brand. We can switch to the other, but please, before switching, guarantee 10 mic per kg Romiplostim for 4 weeks before declaring failure. For the L-Thrombopeg, 75 for 6 weeks before declaring failure. Romiplostim, we have two early on publication in Ain Shams University about the Romiplostim use in the pediatric age group from Dr. Alfi and Dr. Garira Mukhtar, and I finally running reached to the end of her presentation. Thank you.